Welcome to the latest installment of the AST Journal Club series. Today's Journal Club features the AJT article, Inequities in Organ and Tissue Donation and Transplantation for Sexual Orientation and Gender Identity Diverse People, a scoping review. This AST-AJT session is co-hosted by the Women's Health Community of Practice and the Psychosocial and Ethics Community of Practice. In a moment, I will turn the session over to our moderators, Dr. Goni Katz-Greenberg from Duke University Medical Center and Dr. Alexandra Shingina from Vanderbilt University Medical Center. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. If you have a question for our panelists during the Journal Club, we encourage you to participate using the Q&A button in the Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. This Journal Club is being recorded, and the archive will be available on the MyAST website 2 to 3 business days after the session. Finally, when you log off at the conclusion of today's Journal Club, you will see a short evaluation survey link to complete. Please fill out the survey to help us keep our content current and engaging. I now turn the session over to our moderators to begin today's webinar.
Thank you, Brian. Happy to be here. Thank you for inviting us to moderate. I'd like to introduce our two speakers today. The first one is Dr. Leeies, who is an organ donor, critical care medicine and emergency medicine specialist physician, and he serves as the director of research for the Department of Emergency Medicine in the University of Manitoba. He leads a collaborative program of research that focuses on promoting health equity in organ and tissue donation and transplantation, and wants to make sure that this population is well served by us, and has therefore led the formation of a 2SL GLBTQIA plus patient and public advisory team. And for those of you who are not familiar yet with this acronym, it stands for Two-Spirit, Lesbian, Gay, Bisexual, Transgender, Queer or Questioning, Intersex, Asexual, and Additional Sexual Orientation and Gender Identities as a more inclusive term. And through this work, he hopes to inform the reformation of structural and systemic elements in the healthcare systems. Clinically, he also continues to work as a specialist physician with the Transplant Manitoba Gift of Life program, and serves as the director of the EDDI, which stands for Equity, Diversity, Decolonization, and Inclusion for the Canadian Critical Care Society. Our other speaker and talker today will be Dr. Carmen Hrymak, who is also an organ donation and critical care medicine and emergency medicine specialist in Manitoba. She has a Master of Science in Quality Improvement and serves as the Director of Quality Improvement, Patient Safety, and Standards for the Department of Emergency Medicine, and is the chair of the Outcome Improvement Team for the section of critical care in the critical care section. She also strives to incorporate health equity pillar of the quintuple aim for health improvement into her work, and collaborates on work with Dr. Leeies throughout his research program, including the scoping review, which we're happy to having them present here today at the AST Journal Club. Thank you.
Thank you so much. It's our pleasure to be here today. So we'll be presenting this scoping review. And I wanted to start today with a traditional territories acknowledgement. Myself and Dr. Hrymak, we're speaking to you from Manitoba in Canada. We're both at the University of Manitoba. And the University of Manitoba campuses are located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past and the present, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. In terms of conflict of interest disclosures, myself, I hold some research grants from Canadian Blood Services, the Kidney Foundation of Canada, Canadian Donation and Transplantation Research Program, and the Royal College Foundation. Dr. Hrymak has no relevant financial relationships to disclose. And we'll say for the scoping review that we're talking about today, patient and community engagement, which we'll describe further, was supported by an award from the George and Fayou Center for Healthcare Innovation. Our moderators, Dr. Katz-Greenberg has no relevant financial relationships, and same goes for Dr. Shingina. So on to our article and publication, Inequities in Organ and Tissue Donation and Transplantation for Sexual Orientation and Gender Identity Diverse People, a scoping review. Before we dig into the meat of the article, I just wanted to present a few words for a bit of background, a bit of context around the subject matter, not knowing exactly where everybody is at coming to this talk. So a few words on terminology. I'll be using the term SOGI as an acronym, which stands for Sexual Orientation and Gender Identity. And this is sort of an umbrella term that's used to refer to an entire community of people. Other common terms are sexual and gender minorities. And this terminology is meant to be inclusive, but at times it can be limited depending on the context, and is always evolving. And as mentioned, 2S LGBTQIA+ is another common acronym. We heard the definition there, so we won't belabor that, but you may hear us refer to sort of the queer population in any of these ways. I also wanted to just take a second to talk a little bit about sex and gender. This is something that's very much in the media and people are familiar with, but there's different levels of familiarity and comfort, I think, with these concepts. In healthcare, particularly, we have a lot of inconsistent and imprecise terminology, especially when it comes to differentiating sex and gender identity. Often in common language, sex and gender are used interchangeably, as well as in written and medical literature. And when they lack precision for what they mean, it can be difficult to know, really what we're talking about. And other related terms are similarly problematic, like male, female, or man, woman. So just to highlight, the framework that we're using here, sex, which we're really talking about sex assigned at birth, is the genetic, anatomical, physiological characteristics that we use to assign somebody a sex at birth. And that's based usually on an infant's anatomy at birth. Whereas gender is a social or cultural construct. So gender is based on social or cultural characteristics and can change over time. And so when we are referring to somebody's gender identity, one of the common ways we'll refer to them is using these terms man, woman, and those are unfortunately even dichotomous and don't include other diverse gender identities as well. When we see the words in medical writing male, female, that is typically referring to sex assigned at birth. So just an important consideration. And in terms of some further background, SOGI-diverse people make up 10% of the global population. Estimates of this epidemiology have been evolving over time, and we're seeing increased numbers of younger generations identifying as SOGI-diverse. And this statistic comes from an Ipsos Reid survey of 27 countries that include Canada and the US. Importantly, as we sort of mentioned, gender identity and sexual orientation are distinct concepts. We may often talk about SOGI-diverse populations or any of these other umbrella terms, but it's really important to remember that this is not a homogeneous group. Whenever we're talking about a large population of people, there's heterogeneity within that population. And in many cases, there are more similarities between populations than there actually are differences, and there are often more intra-population differences within a group than there are between groups. And so when we consider that, we realize that social identities and lifestyles, as well as lived experiences, will position individuals to experience different advantages or disadvantages. And there's a spectrum of privilege and power even within systemically oppressed or marginalized groups. SOGI-diverse persons, we know, experience inequities in numerous health domains, so not isolated to organ and tissue donation or transplantation. Researchers and community organizations, as well as patients themselves, have called for action to address these inequities. In the organ donation transplantation system, many of the inequities, not all, but many, are related to donation bans and differential policies that were introduced globally in response to the HIV epidemic of the 1980s. And it's our position that policy revision and updates have really not kept pace with our growing understanding of HIV epidemiology, detection, prevention, and treatment. And so we feel there are opportunities to update and revise policies to match our current science. And importantly, the inequities that impact SOGI-diverse populations extend beyond the potential for infectious transmission of HIV or viral hepatitis, and we really argue warrant further investigation and characterization. So on to our scoping review. We'll talk a little bit about the methods. The primary objective of this review was to map out the existing literature on the experiences of SOGI-diverse people in OT/DT systems. As we were starting to look into this question of, what are their inequities, what are they, and trying to understand them, we found that there hadn't been a systematic review or scoping review on the subject that was published. And so we set out to form a collaborative team to conduct this scoping review. We developed a multidisciplinary group of clinical experts, and we also included SOGI-diverse patient and caregiver partners in the development and execution of the scoping review. And so I wanted just at the very top of the talk to take a moment to recognize this patient and caregiver advisory team. So none of them were able to be here today, but I wanted to really express my sincere and very profound, I think, gratitude for this group. So we formed this advisory team to help really direct and set priorities for our research program. They've been fundamental partners in the development of this research program, and they continue to guide ongoing work and future priorities. And these are all people who have come to our group because of experiences that they have had in the OT/DT health system. And that's the health system that we work in, where these patients have faced inequities and stigmatization. And for some, this has changed the trajectory of their lives completely. And really was, I think, people are bringing very meaningful lived experience to the table. In our group, we have 13 patient and caregiver partners currently. These are living organ donors, the caregivers of deceased organ donors, or transplant recipients. They're all folks who have 2S LGBTQIA+ identity, and have participated and collaborated on our research program. They're also people. They're mothers, fathers, siblings, children, partners, husbands, wives. We've got diverse professionals from nursing, physicians, students, educators, sociologists, epidemiologists, all kinds of different occupations. And we've got members from across Canada and the US. They're also strong social advocates. And so this team was engaged throughout our scoping review and its development and interpretation. It's grown a little bit since the scoping review, but I wanted to just highlight and thank that group for their engagement. So with our team assembled, we sought to conduct the scoping review. And first we developed and registered a scoping review protocol in the open science framework. For people who may be more familiar with systematic reviews, it's best practice to plan out what you're going to do with your systematic review and to publish that so that It's clear what your plans were, and then if there's any divergence from those plans, there's some accountability. And for scoping reviews, for systematic reviews, those are published in Prospero. For scoping reviews, there's no official location, but Open Science Framework is a great place to publish and register protocols for studies like this. We conducted this review following the Joanna Briggs Institute Methodologic Guide for Scoping Reviews, and reporting was consistent with the PRISMA extension for scoping reviews.
All right, thanks, Murdoch. We'll switch gears for a minute and I'll talk a bit about our search strategy. So as Murdoch mentioned, we had a team assembled, and then we partnered with a health information specialist librarian who is skilled in knowledge synthesis and methodology. Our search review was also peer reviewed using the peer review of electronic search strategies checklist. And this may look a little different than a systematic review, but for the scoping review, we itemized based on population, concept, and context. So for our population, we looked at people with SOGI-diverse identities, explicitly including sexual and gender minorities, men who have sex with men, and transgender and gender diverse individuals. Our interventions include any interaction with an organ or tissue donation or transplantation system. Outcomes were inequity domains, interventions to mitigate inequities, interventions to ensure the transplanted organ safety, transmission of bloodborne infections, and any other key findings relevant to the review questions. We looked at all study designs as eligible for inclusion, and for publication status, only data published from studies were included for feasibility, and only publications in English were included for feasibility. We looked from 1970 to present as our time frame for included studies. So our systematic literature search was from 1970 to 2021. And we searched medical, legal, and ethical peer review publications at the following databases. We also looked at public-facing government content, health systems reports, and news media, which we'll get into a little bit, and the gray literature. So we used the Canadian Agency for Drugs and Technologies in Health, or CADTH, Gray Matters Checklist, which we found very helpful to search the gray literature, and targeted searches of relevant websites where we were able to pull out some of that public-facing content. So Murdoch and I, as two reviewers, independently reviewed and screened titles and abstracts. Potentially relevant citations were included in full text screening, and we reviewed the full text of all included materials. Any discrepancies were resolved by consensus. For data abstraction, so we used a standardized pilot-tested data extraction form. For the two reviewers extracted information from each citation, and this included the usual ID, authors, year, country of origin, publication type, study design, study population, main outcomes, and then, of course, the inequity domains. So the methods for charting our findings. So we anticipated that the majority of our data would be qualitative in nature. So we imported it and did find that was the case into a qualitative analysis software called Atlas, and then performed a best fit framework synthesis. So we reviewed the data in parallel using a deductive approach of 4 domains. So we applied these 4 domains to the published data: benefits, harms, inequities, and knowledge gaps, which helped categorize all of the information we were qualitatively analyzing, and then performed an inductive thematic analysis to identify additional themes that were not captured in the original framework, and try to maximize the amount of information we could glean from the published literature. And this resulted in our final coding schema. In keeping with the scoping review methodology, we did not assess risk of bias or perform quantitative meta-analysis. And then for patient and community engagement, we had the benefit, as Murdoch mentioned, of engaging our SOGI OTDT patient caregiver advisory team, and also worked with the Community-Based Research Centre, or CBRC, which is one of Canada's leading queer health research, education, and advocacy organizations that can help also translate knowledge to the SOGI and queer community. So reporting, we use the guidance for reporting involvement of patients and the public, or GRIP for reporting. And then to take a look at some of the results. So as you can see, our Prisma diagram, we started off with 2,402 citations. We screened 2,392, 177 were eligible for full text review, and then we ended up including 87. Study characteristics. So this is from 2003 to 2021. Even though we searched from 1970, we only started finding relevant publications in the 2000s. And as you can see, the number of citations increased and is increasing with time on this topic. And as far as citation types, there were 4 kind of main publication types. So medical journals made up 28%. We had reports, law and ethics, and then news and media made up almost half of the publication types as well. The regions of the world that had the most publications were United States and Canada, and then a small amount from elsewhere, mostly in sort of media and a few medical journal publications as well. I'll hand it back to Murdoch to talk about the qualitative results.
Thanks so much, Carmen. So we're going to share a figure with you here. A lot of words on the screen, obviously. This is a word cloud. And if you're not familiar with a word cloud, this is a figure that's generated from our charted findings from the qualitative analysis. And so of all of the relevant quotations that we found and then subsequently characterized and analyzed, the words that were most commonly appearing will be seen as larger in this word cloud and more central. And so before we even begin to discuss the results, I'll ask you to just take a moment and kind of allow your eyes to drift around the cloud and the screen, and just see what you take in from that. I thought every time I take a look at it, I found some different sort of stories kind of starting to emerge and raising new questions. And this is a qualitative way of sort of summarizing text. So I thought that was just an interesting approach that we're not as used to as quantitative sciences or scientists of taking. Okay, so we'll move on. So our qualitative analysis assessed and identified 6 overarching categories. We've looked at benefits of having a SOGI-diverse identity in an organ and tissue donation transplantation system. Interestingly, notably here, we found 0 publications that referred to any kind of strength or benefit of having a queer identity. Maybe not surprisingly, most of the literature was focused on harms or inequities that SOGI-diverse people faced in OTDT systems. There was some literature that focused on specific laws or regulations. And then we categorized one domain as sort of social considerations that didn't really fit well into other domains, and identified gaps, either knowledge gaps, identifying a need for further research and understanding, or implementation gaps where knowledge existed but hadn't yet been incorporated or implemented into practice. And so the majority of the literature that we found focuses on these specific inequities or harms, as well as these knowledge and implementation gaps. All right, now this is a very dense slide. So we're going to spend a little bit of time here. This is a figure that's taken directly from our manuscript, and it's meant to be a visual representation of the central harms and inequities that we identified in the scoping review. So in the center of this sort of web is devaluation and stigmatization. And these were the central forces driving the various different harm or inequity domains that we see in the inner circle surrounding devaluation and stigmatization. And each of those domains of harms or inequities had some various examples that we included in this figure in the sort of external circle reaching outwards through the web. In our manuscript, we present a series of tables that list each individual harm or inequity, the number of citations that these appeared in, and we provide representative examples. Also, as an appendix to the manuscript is the actual full list of quotations and codes. It's a lot of information, but we felt it was important to chart and categorize these in detail, as this was a novel scoping review, really the first on the subject to be published. But these charted findings are a bit too dense for a presentation format like this. So we're going to discuss the specifics here, and if there's any points that you need clarified, very happy to address those as well. So starting in the center with devaluation and stigmatization, and going to the top of the figure, increased infectious risk donor designation. So this ties back to restrictions on donation imposed on members of the queer community in reaction to the HIV epidemic of the 1980s. This, we would argue, is a stigmatizing classification of either somebody's organs or tissues or of the donor themselves as being at increased infectious risk. And that's problematic when it's based on identity rather than behavior. You know, to say that all men who have sex with men have an increased risk of HIV compared to not men who have sex with not men, you know, is I think willfully simplistic and a little too reductive. You know, there are many types of people who live many different types of lives. And, you know, two men, let's say, who are in a monogamous relationship who are sexually active but know that they're HIV negative have a 0% risk of contracting HIV from one another. And so, you know, to discriminate against that population is really not based in science. And so this increased infectious risk designation has led to a lot of the stigmatization in the donation system. And there were a number of publications sort of highlighting that as an issue and calling for action, although not with any specific action points. If we move over to the right, inequitable access. So the devaluation and stigmatization of queer populations restricts access to donation. So organ donation, I think, as many of you know, is possible for queer people. But if you're categorized as a man who has had sex with men in a certain period of time, then you're considered to have an increased risk of transmitting HIV. And that means you are not allowed to donate tissues at all for a large period of time. And you are able to donate organs through a exceptional distribution pathway or a different pathway. Insufficient gender affirming care at the far right here was also an issue, and there was some specific literature dedicated to this topic. Was really highlighted that there's very little healthcare provider training in general for care that is affirming to somebody's gender identity. There's inadequate capture of gender and inadequate precision in differentiating gender from sex assigned at birth in health information systems that we use. And some of the literature identified knowledge gaps in this area that require further research. Interestingly, the application of sex-based modifications to GFR calculation, to renal function calculation, and how these apply to people who have non-normative gender identities, so either transgender or gender diverse folks, and who might be on or off medical hormone therapy, and how that changes, muscle mass and the interpretation of creatinine. So there's a significant knowledge gap there. When we're talking about supply, there were some articles that focused on trying to quantify the impact to supply of both organs and tissues from current policies, and found that current policies certainly restricted, significant tissue donation, as well as corneal donation as a type of tissue donation, with many thousands of opportunities for donation not realized every year because of current criteria. In terms of organs, there's also evidence to show that classifying organs as increased infectious risk is associated with underuse of organs. HIV stigma, sort of at the 6 o'clock of the figure, is really tied into a lot of this, and there's an overlapping population. There are queer people who are living with HIV, and there are non-queer people who are living with HIV. And so a lot of these policies intersect and impact anybody living with HIV, or the sexual partners of people who are living with HIV. And so there's evidence that show this stigma reduces the supply of organs similarly, and impairs prevention and treatment of HIV efforts. Disrespect of bodily remains was raised as an inequity and a harm. And one way that this could be realized is the disposal of somebody's body without use. So disrespecting the offer of a gift of donation after death by declining it without adequate reason. There's also an issue about routine rectal examinations and deceased donation, something you may or may not be aware of. There's a little bit less clarity in the US actually about this practice. In Canada, our national regulatory organization has a guideline document for organ donation programs and sort of how to evaluate donors. And they recommend, still in writing, as a part of the routine risk assessment in deceased male organ donors, that all deceased male organ donors should have a rectal examination to examine for evidence of receptive anal sex, for the purpose of then classifying that donor as likely a man who's had sex with man, and therefore being at increased risk of HIV and hepatitis. This is a very politically sensitive examination. It's not based in science. There's no science that supports that this examination is predictive of HIV or viral hepatitis. Really, to be frank, it's not even really clear what you would be looking for necessarily in this exam. But I think even more concerning than the utility of the exam is that there really isn't a standardized approach to informed consent for this examination. It's folded into the donor assessment consent that we would obtain from a substitute decision maker. And may be very relevant, especially for people who are oppressed or have experienced discrimination, as forced rectal examinations are used as a method of persecution for queer people in some countries. And so this was a sort of a surprising element that we thought warranted discussion and mentioning. At 9 o'clock, SDM, or substitute decision maker suffering. After somebody dies or has a devastating brain injury and is going down the deceased donation pathway, the substitute decision makers have come forward, and this populated some of the news media articles to really tell their stories of how they felt rejected and abandoned after offering a loved one's organs or tissues for donation, a very generous and charitable act. if that's met with rejection on the basis of that person's identity, people have described feeling like the patient's offer was devalued. They describe compounding grief and suffering because this is happening at the time that somebody is dying or has died. And then, on top of being told your loved one has died, when you offer to donate their organs because it's what they wanted, you're also told, "Ooh, sorry, we can't accept their tissues because they were sexually active gay men." Really adds to grief and suffering and leaves people with an inability to enact final wishes of their loved ones. And the last major category was transparency. So we identified some published concerns with communication in different forms. One domain was in our informed consent processes, documents, and that might be going through the process of getting consent for a living organ donor. There were issues with privacy that were identified there. That might be informed consent for, like we just talked about, risk assessment and workup of a potential deceased organ donor or actual consent for donation. And then there were also concerns with public-facing content being one-sided or persuasive, where organ donation organizations, I think with the best of intentions, are reaching out to queer communities, reaching out, let's say, doing some publicity during Pride seasons, and really trying to communicate to the queer community that, it is possible to donate organs and this is how you do it, and et cetera, but without acknowledging the structural stigma and inequity that's built into our system. And so that's been criticized as being persuasive or sort of one-sided. Yikes! So that's a lot of content to review, but based on all of these findings, we wanted to also develop recommendations. And so before we developed our own recommendations, we sought to see if there were any published recommendations in the literature as well. And there were a few. So this list are published recommendations from our scoping review, where we found either articles or guidelines that were published. And those included, number one, conducting a reevaluation of the currently discriminatory system, so sort of a call to reevaluate and update the system. To develop evidence-based, sex and gender-neutral, behavior-focused eligibility criteria for organ and tissue donation. And we've really seen this evolving in the blood donation system. Canada has recently changed its donor risk assessment for blood donation to sort of pivot from a gender-based question, where we're looking at men who have sex with men, to say we're going to actually look at the specific sexual behaviors that are associated with an increased likelihood of acquiring HIV or viral hepatitis. And so they've shifted, and the US has also just shifted, I believe, or announced that they've approved a shift to gender-neutral behavior-based screening. We'd like to see this happening in organ and tissue donation as well. Authors also had published calls to destigmatize relevant terminology. There's some evidence that just the act of stigmatizing an organ makes people less likely to use it, but there's evidence to show that, particularly in the current climate where there's a shortage of organs for those who need them, when a transplant patient is listed for transplant and they're offered an organ that has been classified as increased risk, the evidence shows that if that potential recipient declines that organ, they actually have a higher risk of dying or of getting so sick that they're delisted. And so that stigmatization may be doing harm to transplant recipients and not really informing them or empowering them to make their own decisions, as we would have hoped that knowledge would have done. Fourth, to decrease or remove current abstinence requirements for two-spirit, gay, bi, trans, queer plus donors. Number 5, to enhance HIV and viral hepatitis detection and prevention methods. And 6th, to develop the capacity for and to provide gender-affirming care to transgender and gender-diverse persons. So these were the 6 recommendations that had been published that we identified in our scoping review. We also identified some published knowledge gaps from the included citations. And so again, there were calls really to highlight that transgender and gender diverse healthcare needs are a significant knowledge gap, and that there's research needed to better understand these. Number two, the calls to better understand the incidence, prevalence, and predictors of HIV and viral hepatitis. So some concern that some of our current understanding of epidemiology is really based on quite limited evaluations of populations of people who have some very specific risk factors and may have multiple risk factors. So, you can imagine to understand what the incidence of HIV is in the queer community, you would sort of need to have a large sample of the queer community and no, but a lot of studies are based on really small subpopulations that are at quite an increased risk, like let's say queer youth who are street connected, potentially also using IV drugs and involved in sex work. This is a very different subgroup than any number of other subgroups of queer people who would have different risk profiles. The likelihood of transmission of HIV and viral hepatitis through tissue donation. So, tissues, in particular corneas, we know are avascular, and it's thought that the risk of transmission through these potential vectors would be less than organs, but it's not fully understood. There have been some case series of cases where there had been an issue where a donor either had HIV or hepatitis and it wasn't recognized. And it was transmitted through organ, but not some of the tissues that they had donated. And so this was identified as a knowledge gap, as well as the impact of current discriminatory donation eligibility criteria on transplant recipients. So we know a little bit about this, but that evidence and body of research, I think, could be much more detailed. So I'm going to pass it on to Carmen to talk about our synthesized recommendations.
All right, thank you. So based on all of what we've talked about so far, we came up with 11 main recommendations. And there are quite a few, but I'll go through each of them and then allow time for questions at the end. So recommendation 1 is to acknowledge the structural stigma and harms to SOGI-diverse populations with respect to inequities that exist, and take ownership of these as an OTDT community as a first step towards reconciliation with SOGI-diverse communities. We recommend striking working groups with appropriate stakeholders to critically review inequities and harms that SOGI-diverse people face in their systems. To authentically engage with SOGI-diverse patient and public partners to identify clinical service delivery priorities, research priorities, funding allocation, and informed policy formation, appropriate representation of relevant SOGI subpopulations, including those with intersecting identities from other systematically marginalized groups, such as race, socioeconomic status, geography, etc., should be explicitly sought. To critically review their informed consent processes and any communications for evidence of persuasive communication, and to ensure that SOGI-diverse perspectives have been considered and revise these accordingly. Communication should be standardized and scripted where appropriate. This came out in some of the public-facing material where the information to the public was not as transparent with respect to potential discrimination that SOGI-diverse patients would face going through the OTDT system. Take action to remove routine rectal examinations to screen for evidence of receptive anal sex in potential deceased organ donors, and denounce this practice. If felt to be relevant diagnostically, specific standardized informed consent should be obtained and documented. But the first recommendation would be to remove entirely. Number 6 is to decrease or remove the current abstinence requirements for seronegative sexual partners of persons living with HIV who have undetectable viral loads. So non-detectable, non-transmissible patients should not require abstinence periods. Advocate for the development of inclusive practices that ensure the protection and affirmation of transgender and gender diverse donors and recipients, including accurate data collection of sex, gender identity, and pronouns. And I think we all know that lots of areas of healthcare are working to improve this. And this is another area where it's very important, as Murdoch mentioned, especially when it comes to calculation of renal function, et cetera. We need to first develop inclusive practices and then understand our populations better. To critically review living donation system information sharing processes regarding the privacy of potential SOGI-diverse living organ donors to prevent harm from inadvertent disclosure of their SOGI status through and after their engagement with the system. So you can imagine going through the system, wanting to protect parts of your identity and have inadvertent disclosure of your SOGI status multiple times over, and a way to be respectful and have privacy where possible in this area is important, and an identified recommendation. Number 9 is to support future research to understand existing or potential benefits of SOGI-diverse identities in OTDT context. So as we found, there were no published potential benefits of a SOGI-diverse identity in OTDT, probably because research has so far been looking at inequities and harms, but looking into this in the future, we think is very important. To support future research, including disaggregated analyses to evaluate the impact of individual SOGI-diverse identities on access and outcomes through an intersectional lens. And lastly, to support research that considers the impact of intersections of social identities from systematically marginalized populations, example, race, ethnicity, Indigenous identity, ability, education, socioeconomic status, et cetera, in combination with their SOGI-diverse identities as well. That was a lot of information, but if you take a look at the paper, it's also summarized there and can be referred back to. And this is just kind of a brief summary during our question and discussion period to see if you have any questions for us. That kind of concludes our presentation part, and I'll turn it back over to our moderators.
Well, thank you so much. And I want to congratulate both Dr. Hrymak and Dr. Leeies on their effort and for spearheading this effort to make sure that SOGI-diverse population, whether patients or not, are included and seen by medical community. It was really an absolute pleasure to read your paper. So I would like to encourage the audience to submit questions via the Q&A option at the bottom of your screens. And maybe while we're waiting for some questions, I can start off with a couple of my own. So I honestly was quite surprised by the relative paucity of information out there on this topic. It seems like the majority of the published literature is coming from Canada and United States, and there is a little bit less, some in Europe, but there were other countries like Australia, India, and even Russia. And I was wondering if in your review you have noted any differences between approach on this topic according to the geographical region.
Thank you. Yeah, that's an interesting question. Certainly, the majority of the literature was from the U.S. and followed by Canada. A little bit from Australia that was sort of similar to the literature in the U.S. and Canada, and I think medical systems are related, where they're looking at epidemiology of HIV hepatitis, trying to evaluate the impact of some of their current criteria on organ donation rates. And so there was a little bit of literature in Australia where they had identified potentially missed donation opportunities because of the restrictions that they have in their system. A lot of the literature from other places actually came from the news media. And so, India, Russia, we didn't find any primary medical studies there, but news media articles sort of highlighting inequities or otherwise. But I think more work is needed to better understand in a granular way how these different international donation communities are addressing this issue, what their current policy gaps are, and opportunities to enhance equity.
Thank you so much. It seems like we have a question from the audience. What were the themes related to the intersectionality between the SOGI and other minority groups, such as racial, socioeconomic, citizenship status? Is there anything that you guys have noticed in your review of the literature?
Yeah, that's a good question also. So this was, I think, more so a call for future research to really take an intersectional approach and look at SOGI-diverse populations and to consider all of the other intersecting identities that make up a person. So how do different racial or ethnic groups or subgroups, if we're thinking of the SOGI umbrella, how does race and ethnicity impact a SOGI person's experience versus not? And so the existing literature didn't get into that level of granularity, but we feel that it's an important consideration for any future study to incorporate.
That's great. Thank you. Another question that we had, it's have you come across anything in the literature that describes a specific intervention on a provider level, on a center level, transplant organization level that could improve these disparities of SOGI-diverse population? Or can you think of one thing that we can all do after this webinar today that we can bring to our practice to try to close that gap?
That's a great question. We didn't find in the published literature any specific, tools or techniques within the scope of this scoping review, but there are a number of publications and resources for people who want to improve their own individual cultural humility, improve some of the expertise that they may have dealing with queer populations or treating them in your clinical settings. There's a great resource, and it's, what I think I have right here, actually. It's the Fenway Institute. I believe it's called the National LGBTQIA+ Health Education Center. Has an excellent online resource with lots of free courses and webinars. A lot of them have CME accreditation as well. I've got a link I'll put in the chat. It is a fantastic resource, I think, to get started with enhancing your own cultural humility. And it could be something as simple as just interfacing with a patient in a way that's more welcoming and inclusive. And so I would encourage people to consider even the way you talk to patients and whether you gender a lot of your conversation or language. I know for myself as a clinician, when I'm meeting patients, I often will, check their identity and will ask them using an honorific like Mr. or Mrs. As a signal of respect. But when you come to somebody and you put that assumption on them, well, hi, are you Mr. So-and-so? That if somebody has a non-binary or non-normative gender identity, could really set up your clinical encounter at the offset with, an offense and send an unwelcoming message. So just thinking about the way that you use language when you're interfacing with patients, do you use these automatic assumptions? It's also not supernatural for me linguistically to introduce myself and say my pronouns are he, him. But I'm trying to incorporate that a little bit more into my practice and experimenting with it and figuring out ways I can meet patients and have them self-identify, their own pronouns or identity. And it's individual, and I think it depends on the situation and the individual patient as well. But that would be my advice for a way to try to incorporate care with a little more inclusion today.
Yeah, and I fully agree with Murdoch, and it is those very initial interactions, even though it may not be the time you're first mentioning organ donation or asking about someone's willingness or a family member's willingness to donate, just that initial interaction and kind of relearning how you approach patients. So that's a great resource that Murdoch has provided. and then those assumptions. So one way would be to kind of ask a patient, what is your name? Which seems like you may already know that information going into the room, but that gives them an opportunity to provide a different name to express their identity, instead of starting off by saying, hi, I'm Dr. So-and-so, you must be Mr. Smith. I've read all about you. But what's your name? How would you like me to address you? A little bit more open-ended, inviting questions. And another thing we found is any attempts to display a welcoming environment or inclusive environment, symbolism of inclusivity and that it's safe to be SOGI-diverse in this space, like wearing a rainbow flag or having something posted in your organ donation areas or in your hospitals. That's another thing that you can look into, and we've been working on locally as well. And then the more specific to kind of your organ donation practices, I think we were not even necessarily aware of all of the intricacies of what goes into the questions to patients and the physical exams and where these practices came from. So I think just learning what your institutions do and kind of critically appraising your current practices and bringing that to your leadership and bringing this information back will stimulate discussion where there may not be any right now, and it just is not on people's minds. It hasn't been reviewed in far too long. It's outdated, and I think just being aware of what your practices are and where the gaps are would be another first step.
Thank you. Those are great tips. I think I will incorporate some in my practice. So one question I have regarding the section that you focused on the transgender population, I was actually pretty struck by a sentence there that said that you identified a central issue that these patients often feel invisible. In donation and transplant, of course, it could be in any medical field, but here we're talking about transplantation and donation. And you later noted several gaps in area of research, such as drug interaction, risk of venous thrombosis, cancer with the hormone therapy, or you already talked about the interpretation of GFR equations, or specific psychosocial support that will actually go to their needs. If you had to pick one of these four, any others that you thought of, what would you start with? What would you think would be the most beneficial and most impactful?
That's a great question. I think for patients, if we take a patient-oriented approach, I think ultimately patients want to be seen and valued, as humans. And so I think our capacity to interface on an interpersonal level is probably the thing that ultimately is going to help people the most. I don't want to speak for the transgender community. We're actually doing some work right now where we're doing a series of in-depth interviews with our patient advisor team members and other people who have lived experience to more in-depth understand from their perspective what they want. But I think the signals that I'm seeing so far are that is the most important thing to patients. And we were really surprised to learn, we advocate for enhanced data collection for all these variables so we can measure inequities and design strategies to mitigate them. But patients describe a huge benefit, just as you said, of being seen and being represented. And so when you are registering at a hospital and you see your identity reflected in the intake materials, that validates you as a person. When you go try to register and you don't see yourself, many people wouldn't be able to, I think, imagine even what that would feel like. But that normalization and representation is something that's been expressed as being important to patients also.
Thank you. Looks like we have our next journal club waiting for your paper to be.
So
Any final words, Sasha? Sorry, yeah.
No, I think we only have 1 minute left, and I just wanted to thank Dr. Hrymak and Dr. Leeies for coming and presenting and discussing this very important topic. And I'm hopeful that all the participants have taken away a little something that they can change in their daily practice from this webinar. And I will, we can also make sure that we send the very helpful link that I was just looking at that you sent for National LGBTQIA plus Health Education Center to all of our readership, both at AST, the PSECOP, and our women community of practice. So thank you so much.
Thank you so much for having us.
Thank you so much for inviting us.
AST would like to thank Dr. Leeies, Hrymak, Katz-Greenberg, and Shingina, and the leaders of WHCOP and Psychosocial and Ethics, and all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's WHCOP and PSECOP, please visit myast.org/COPS or connect directly to the WHCOP and Psychosocial hubs online. Thank you all again for today's excellent session.
Thank you.